Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. Rain. Today, we will continue talking about aging and the adipose tissue, obesity in particular. And for that, we have the honor of having Dr. Peter Mancuso. He is an associate professor of nutritional sciences and graduate program in immunology, School of Public Health, University of Michigan in Ann Arbor. Welcome, Dr. Mancuso.
Well, thank you for inviting me.
Thank you. So we are going to base our discussion on a paper that Dr. Mancuso and his team published in Frontiers in Endocrinology in 2019. The title of the paper is The Impact of Aging on Adipose Function and Adipokine Synthesis. So it's not a secret that obesity became an epidemic, but at the same time, aging is one of the big achievements of modern medicine. So people are aging, but in a parallel fashion, obesity is also growing. So it's interesting the way Dr. Mancuso analyzes this problem, because I saw in his paper that there is an intersection between the two processes, aging and obesity and changes in adipose tissue. So my first question for Dr. Mancuso is, what sparked your interest in the combination of these two factors?
Well, we've seen over the past several decades an increase in obesity in the United States, in Europe, and in other developed nations. And we're starting to see this in countries in where there's this nutrition transition taking place, in which when people adopt the Western lifestyle, along with it, there's a dramatic increase in the prevalence of obesity. And in these developing countries, there's, thanks to public health measures, there's fewer people dying of infectious disease and living longer lives. But with the nutrition transition, you're seeing a lot more people developing overweight and obesity as a consequence of this Western lifestyle, highly processed food, and limited physical activity.
Yeah, and that is something that is becoming more notorious and is affecting different aspects of life, and it's associated with also different illnesses. So when I went to review what is going on during aging, there is a term that is highlighted in every paper, and is inflammaging. So the fact that there is inflammation is a key component, and probably is in the middle of both processes, right? Aging and obesity. So in terms of inflammation, how do you connect those two processes?
So the term inflammaging, as a lot of people use, came from Claudio Franceschi, and he used this term to describe this chronic low-grade state of inflammation that you see with aging that's associated with increasing oxidative stress. So as we age, we have problems quenching free radicals that are formed in various cells and tissues, and this is thought to be an important trigger to activate this chronic inflammatory response. But along with this, what we're seeing now is a lot more people with excess adiposity and loss of metabolic control. And with that, you have an activation of adipokines, or hormones produced by fat cells, that play an important role in the process. You have pro and anti-inflammatory adipokines that are produced by different adipose tissue depots, and they seem to play an important role in the entire process.
Yeah, and I see that it's actually a two-way avenue, right? Because the aging is associated with changes in the fat distribution, and at the same time, the fat tissue, the adipose tissue, changes as you age as well. So there are things happening at the same time. So and you mentioned that inflammation is something that is there, and in your paper you attribute a part of those inflammatory processes to things that are happening in the adipose tissue. So I want to dig deeper into the adipose tissue. So let's start by the fat distribution. How is fat distributed in the human body under physiological conditions?
So under physiologic conditions, you have the primary or the large adipose tissue depots are first the subcutaneous adipose depot, which is the largest one. And this is the layer of adipose tissue right underneath the layer of your skin. And it's distributed throughout your body. And there is some differences between men and women in that regard. The next largest depot is the visceral adipose tissue compartment, which would include adipose tissue that surround the internal organs. Within the layer of adipose tissue underneath the rectus abdominis muscle within the visceral cavity. This is the next largest and very important, and it's associated, its size, its control, it's the number of adipocytes and size of adipocytes are highly correlated with metabolic disease. So the role of the adipose tissue is to, first, it serves as a storage vessel for excess calories in the form of triglycerides. And then it also plays an important role as a hormone producer. It secretes a number of different types of what are known as adipose tissue derived factors that control metabolic processes locally and distally.
So we know that those different types of adipose tissue are not only different in terms of anatomical location, but they are metabolically different and associated with disease or different functions. So let's talk about first about this subcutaneous fat. Why is it important? Is it associated with disease, or is something that we actually need?
It's something we all need. Adipose tissue. When adipose tissue is unable to perform its normal physiologic functions is when you have problems with metabolic disease. So first of all, what does subcutaneous adipose tissue do? It stores excess triglycerides. It serves as an important source of energy in the case of when calories aren't available. So it plays an important role in regard to the delivery of nutrients. It also is important in regard to its thermoregulatory capacity. So you need adipose tissue, subcutaneous adipose tissue, to serve as an important means of thermal insulation. And then the other important role subcutaneous adipose tissue plays is it serves as cushioning. It serves as cushioning for muscle and bone, and in that aspect, it's very important. It's the long-term triglyceride storage depot, and that's particularly important when people are undergoing weight loss. The first depot to show change is the visceral compartment, followed by the subcutaneous compartment, which is more of the long-term storage vessel.
So that means that the visceral fat, in terms of storage, should play a secondary role, and when it starts becoming primary, that's associated with disease. Is that a right approach?
Well, the turnover of triglycerides is more rapid in the visceral compartment, and that could be primarily due to its location. It's in the viscera. The supply of blood, it is the first organ whose secretion of triglycerides reaches the liver. So in that regard, it's very important in terms of the turnover of lipids during instances when there isn't enough energy stored or energy available. So it's the acute or the short-term energy storage depot. It is more prominent in men compared to women. And when it expands, it has a tendency to expand in the form of larger individual adipocytes that increase by the process of hypertrophy rather than hyperplasia. Whereas the subcutaneous adipose tissue, very effective at storing triglycerides, but when it's no longer capable of taking in triglycerides, you'll see more storage of lipid in the visceral compartment. And the visceral compartment has limitations in regard to its ability to expand. And you have a greater number or a greater size of adipocytes that increase their capacity to take up triglycerides in the form of hypertrophy rather than hyperplasia. So it's this limitation of the visceral compartment to effectively take up lipids that leads to problems with chronic disease. So you have lipids spilling out, going into other tissues that lead to metabolic disease.
So we could say that the hypertrophy and hyperplasia are different, and the first thing that happens then is hyperplasia, right? And as long as you can develop that hyperplasia, you are still okay. But as long as you have to go into hypertrophy, that's when problems arise, right?
Yes, there's a limited size in which the adipocyte can expand, and that's affected by genes that control the ability of the adipocyte to take up lipid. It's controlled by structural tissue collagen that's deposited by fibroblasts within the adipose tissue compartment. So when adipocyte now can no longer expand to control or to hold in the or to accommodate the increase in fatty acids or triglycerides, I should say, it can spill over into the blood. It can lead to inflammation within the tissue, and it can lead to chronic low level systemic inflammation as well.
Yeah, and before we go down that route of inflammation, you mentioned that there are differences between male and female. What determines that difference in fat distribution?
So for women, their fat distribution is affected by estrogen, and estrogen plays an important role in lipoprotein lipase metabolism within the subcutaneous adipose tissue compartment. And in that instance, you have the ability of those adipocytes to expand through the process of hyperplasia in the subcutaneous compartment, which is a safe place to store excess lipids. And through that process, you get expansion of adipose tissue, but it's a safe way to store this excess triglyceride in those tissues, and you get less inflammation associated with that type of expansion of the adipose tissue depot.
Yeah.
Now,
So,
when that capacity to do that is substantial, but there are limitations there as well. When estrogen levels decline during menopause, you'll start to see lipids now being deposited above the waist in the abdominal compartment, in the visceral and the subcutaneous abdominal compartment, which is associated with the risk of metabolic disease.
yeah, that's very interesting how with time the behavior in terms of management of lipids is very similar between male and female, and that has to do with the hormonal balance actually and imbalance. So once the visceral fat is starting to be overwhelmed, you mentioned that there are some ectopic deposits of fat, and then an inflammatory response happens. What are the mechanisms to trigger that inflammatory response?
So it's tissue specific, and it affects different tissues in different ways. So when the lipids spill over into the liver, you get hepatic steatosis, where the liver fills up with triglycerides, and associated with that, it can impair liver function and lead to a condition in which the liver develops a scarring or the deposition of collagen and fibrotic tissue in the form of a non-alcoholic fatty steatotic hepatitis. In other words, the liver can become dysfunctional as a consequence of this accumulation of lipid leading to a fibrotic condition. In the muscle, the lipid can disrupt insulin receptor signaling such that the insulin receptor cannot signal properly and mediate the movement of the glucose transporter to the surface of the muscle cells, the myocytes, leading to their impairment in regard to glucose uptake. So there's insulin resistance within the muscle as a consequence of the lipid being deposited in the muscle cells.
So there are changes in every organ.
Oh, yes, that's just two that are most well described in the literature. But other tissues, you'll also see an increase in the deposition of lipids in those tissues as well. In regard to the inflammatory response, there's a number of things that occur. One is that there's going to be a change in the number of circulating white cells or leukocytes. And the number of these cells increases with increasing adiposity in a number of studies that have been published in the literature. So you get more immune cells, you get oxidative stress, you get lipotoxicity. That's a process in which the lipids can disrupt mitochondrial metabolism within individual cells, and they can produce reactive oxygen species as a consequence, and it can impair their ability to for protein synthesis for a number of normal physiologic functions. In terms of changes in the inflammatory process, this is where the adipokines seem to come into play, in which leptin levels rise. And leptin is a pro-inflammatory adipokine that can activate a number of inflammatory processes throughout the body.
Yeah, so the adipose tissue becomes like an endocrine active organ, right? It's no longer seen just as a storage unit.
Yes.
But it actually triggers a lot of inflammatory responses. So you mentioned that the inflammation that happens in the adipose tissue has to do with different cells, and but one of them is the macrophage, right? So the phenotype changes. How does it work?
Yeah, so this is an interesting process. So as those adipocytes accumulate triglyceride, they increase in size and diameter. And during that process, some of those adipocytes die through some type of a programmed cell death. Perhaps they die through apoptosis or necrosis. The literature isn't exactly clear on exactly how this process occurs. As this tissue expands, there's an elaboration of chemokines. These are cytokines that attract monocytes, neutrophils, and many other different immune cells, T cells, to the adipose tissue depot. And these cells, the monocytes will take up the lipids, the T cells will become activated, and you'll get a change in the type of macrophage from an M2 type, which is more of a anti-inflammatory quiescent type of a cell, to an M1 type, which is more of a pro-inflammatory type of a macrophage that has the capacity to secrete pro-inflammatory cytokines. So there is this increased inflammatory response that occurs as that tissue expands. Some of these mediators spill out into the blood, and this contributes to the systemic inflammation.
Yeah, that ends up being self-sustained. One of the aspects that goes beyond the inflammatory cascade that caught my attention is the existence of brown fat. So this brown adipose tissue, is it something that is significant in the adult life?
Yeah, so there were a number of studies done in the past 10, 15 years looking at adipose, brown adipose tissue in humans. And previous to this, it was thought that brown adipose tissue was only important in hibernating animals and in infants. Well, it turns out that adults have a significant amount of brown adipose tissue that becomes activated when we're exposed to cold. And in animals, for example, there's an increase in brown adipose tissue activity with cold exposure and exercise. In humans, the trigger for brown adipose tissue activity seems to be primarily mediated by exposure to cold. And it's kind of controversial as to whether exercise activates human brown adipose tissue. But what brown adipose tissue does is it increases heat generation. And it's an important means of thermogenesis when we're exposed to cooler temperatures. The activity of brown adipose tissue changes during the year. When we have winter, you'll see higher levels of brown adipose tissue activity in people who are exposed to the ambient temperatures outside. So studies done in humans have shown higher brown adipose tissue activity during the colder months as compared with the warmer months of the year.
And is this something that changes with age?
Yes. So as you age, the amount of brown adipose tissue, or the activity of the brown adipose tissue, perhaps declines with age, and this brown adipose tissue mediated thermogenesis declines as we get older.
One of the aspects that I want to highlight, and you already mentioned that, but I want to make it clear for our audience, is the role of adipose tissue hyperplasia versus hypertrophy, and how, depending on which one is chosen by the adipose tissue, there is insulin sensitivity versus resistance. Mm-hmm. How does that work? Can you elaborate a little bit more?
So this is where the inflammatory process is thought to play a major role. So once you have this expansion of the individual fat cells, the adipocytes, by the process of hyperplasia, you have this inflammatory environment. And the cytokines that are produced in this environment actually suppress adipogenesis. And as a consequence, those fat cells now can die through the process of apoptosis, or perhaps another type of a programmed cell death. And when that occurs, you're recruiting more inflammatory cells that have to remove those, the dead cell components, the excess lipids, and so on. And during that process, mediators are produced that inhibit adipogenesis. So you have this kind of self-promoting expansion of that adipose tissue through the process of hypertrophy rather than hyperplasia as a consequence of the local inflammatory response.
Perfect. And as we see, the adipose tissue is central, and some of the signaling that emerges from the adipose tissue has to do with the adipokines that you mentioned before. So one of the things that I loved about the paper is that you mentioned individual adipokines and what role may they play during aging. So if you don't mind, I'm going to start one by one to see if you can establish and define the role of each one of them for us. So you mentioned leptin, and I liked not only the role of leptin as an adipokine, but how it regulates appetite and it changes between male and female. How is that?
So the amount of leptin you have circulating in your body is proportional to how much adipose tissue you have. Women typically have more adipose tissue than men, so they have more circulating leptin. What leptin does, it does a lot of different interesting things. So for one, it plays an important role in appetite regulation. So after you consume a meal, your adipocytes now have a certain amount of triglyceride, and it affects the expansion of the adipocyte individually. As if you were to fast a number of hours, that adipocyte would start to shrink as it would give up triglycerides. That would lower levels of circulating leptin. And as a consequence, the signaling events that occur in the arcuate nucleus in the hypothalamus would, the signals that would be mediated by leptin would decline. And you would get an increase in signals that would activate the hunger response. And that's mediated by not an adipokine, but a hormone produced by the stomach called ghrelin. The brain would be more sensitive to ghrelin, making you hungry. So that's one important thing leptin does in terms of appetite regulation. As leptin levels increase, it suppresses appetite. But when you think about that, you think, okay, if that's true, why do we have this high prevalence of obesity? Why isn't leptin inhibiting appetite? And it's thought that as adipose tissue increases, as leptin increases, there's this process of leptin resistance that occurs in which we become less sensitive to the leptin signal, and leptin isn't as effective in suppressing appetite. So that's one major function that leptin plays in terms of feeding and appetite.
So there will be like a down regulation of receptors in the hypothalamus?
It's a number of things. So it's a downregulation of the receptor, and there's an inhibition of leptin receptor signaling that occurs as a consequence of a kind of a feedback inhibition loop that occurs within the intracellular portion of the leptin receptor.
Yeah, there are some other adipokines. Some of them I'm familiar with, and some others I am not. Obviously, I'm not an expert, and I want to touch on some of those. You mentioned that some of them are pro-inflammatory, some others are anti-inflammatory. Leptin belongs to the group of pro-inflammatory. There are some others like resistin that actually, to be honest, I hadn't heard about it. So is this something that exists in humans?
Yeah. So resistin was discovered early 2000s by, I believe, Rexford Ahima at the University of Pennsylvania. This is a really interesting adipokine that in mice is produced by adipose tissue and macrophages. But in humans, resistin is produced by macrophages, and it's relevant to metabolic disease in that it plays a role in insulin sensitivity. So as resistin levels increase, it produces insulin resistance. So resistin resists our ability to sense insulin. That's kind of where it got its name from.
Excellent. So there are a few others. Obviously, the classical interleukins like interleukin 1, 6, 12, 18, tumor necrosis factor alpha, all of them play a role, and the adipose tissue is able to produce them, right?
Yeah, it's actually the immune cells that are increase in number in the adipose tissue that produce these classical cytokines that are pro-inflammatory.
And they are also associated with insulin resistance, as I understand?
Yes. They can play an important role in inhibiting adipogenesis and preventing the expansion, the increase in the number of the adipocytes, and they play an important role in reducing insulin sensitivity as well.
Excellent. Let's move on to anti-inflammatory adipokines. Probably the most famous is adiponectin. What can you tell us about this one?
So this one, adiponectin, is really interesting in that it's of all the adipokines, it is present in blood or serum at the highest level. It's present in microgram per ml quantities, and when you compare it to something like leptin, it's a very big difference. Highest levels of leptin you might see in someone are the tens of nanograms per ml. So it circulates at a very high level. Adiponectin is anti-inflammatory. You'll see higher levels of adiponectin in women than men. You'll see higher levels of adiponectin in people who are leaner than people who have more adipose tissue. And it turns out that the adipose tissue depot that's most important in producing adiponectin is the bone marrow adipose tissue. And as we age, adiponectin levels increase. And this is thought to be due to the expansion of the bone marrow adipose tissue in bone that would occupy the space that would have been occupied by the hematopoietic cells, which decline with aging.
And it's a protective factor?
Yeah, it produces insulin sensitivity. It makes your tissues more sensitive to insulin. It inhibits foam cell formation, so it's important in regard to reducing one's risk to cardiovascular disease, atherosclerosis in particular. And it has a number of other anti-inflammatory effects.
Excellent. So there are a few others that I had never heard of. Vaspin and Omentin 1. What about this?
Yeah, so less is known about some of these other anti-inflammatory adipokines. So Vaspin, it declines with aging and insulin sensitivity. For Omentin, this is another anti-inflammatory adipokine. It's produced by omental and epicardial fat. This would be the adipose tissue around the heart and the greater omentum in the stomach. And it is also important in terms of downregulating inflammatory responses. In terms of what happens with age, so Omentin 1 levels increases with age and with weight loss, and when people consume diets that are rich in olive oil and people that exercise, you'd find higher levels of Omentin 1.
Yeah, that's great. The way you presented in the paper, and there is a concept that is central to the paper again that you mentioned, is that it's good for us that we are aging and we are achieving, more longevity, but at the same time, obesity is interfering with with a healthy longevity. So what is an outcome that we don't want to experience is to live longer but sick, right?
Yeah.
So and I think that's probably one of the central points here. So the intersection between aging and obesity lies in the adipose tissue, and the importance of the adipose tissue is clear. So my last question is, what is the takeaway message from this paper for researchers and the general public alike?
In terms of adipose tissue and its role in aging and aging well, the take-home message would be that we want to live a long life, but we want to live a life in which where we have great health and we are functional and we can and live independently. And if we maintain a healthy body weight, we can have a more healthful life outcome in terms of avoiding chronic disease. It's when there's this accumulation of adipose tissue, particularly in the central region around your abdomen, that metabolic function can decline, and then chronic diseases can increase, and then a decline in quality of life. So we want to maintain a healthy body weight throughout our lives, and the way to do that is to avoid or try to limit the amount of processed foods that you would consume, because you'd have a tendency to consume more calories from highly processed food compared to whole foods. So if you have choices, choose whole foods as opposed to highly processed foods, and to move, to exercise at least a half an hour a day. And through choosing a healthier diet and maintaining your physical activity where you're moving around at least a half an hour a day, you can reduce your risk of excess adiposity and perhaps the chronic disease associated with that as you age. It's never too late to start exercising, whether it's aerobic exercise or strength training. And this is something that is actually more important as we age.
Yeah, and that's great advice. And this way we come to a close. And I want to thank you for sharing your knowledge with us today, your wisdom. And the paper was very interesting, and it shed light on multiple aspects, and I think put the adipose tissue in the spotlight as it should be, because it's definitely central in both processes, obesity and aging. And I want to close by thanking Dr. Mancuso. Thank you so much for being here with us. And we will follow up on your research, and in the future probably we will contact you to see what's new in this interesting field.
Thank you, Ephraim. It was my pleasure, and thank you for calling me up and allowing me to talk about this work. I really appreciate it.
Thank you so much. And for our audience, the link to the paper is going to be found in the description of the video, and see you in the next episode.